Good morning. This is Dr. Nithya, Assistant Professor, Department of Behavior. Today we will discuss about bacterial infections. So, what is a pyodoma? Pyodoma is defined as any purulent skin disease. That is, bacteria which is infecting a skin is called as pyodoma. It's the most common skin infection which occurs in the infants because of organism from either maternal vaginal canal or nosocomial infections also. So, what are the common organisms which we find during pyodoma as gram positive, which is Staphylococcus aureus and Streptococcus pyogenes. Now we are going into overall classification. Pyodomas in general is classified into primary and secondary pyodomas. Secondary pyodomas are nothing but those which are caused on pre-existing skin infections like psoriasis or any other dermatosis. And coming to main thing, primary pyodoma, it is further divided into superficial and deep. First, we are going about superficial. Superficial is again divided into follicular and non-follicular. First, we should know what is follicular. That is, whenever we see a hair follicle, the entire canal, it is called as follicular. So, if infection occurs only in those follicular part, it is called as follicular infection. But it is spreading along the other surface. Not only the follicle is involved, the other surface is also involved, then it is non-follicular. So, the first example of follicular infection is follicular impetigo, chronic folliculitis of plague. The second one, non-follicular superficial infection, we have impetigo. Now going into deeper infection. Again, in deeper, we are dividing into two types, follicular and non-follicular. So, when the infection is going still more deep than the superficial follicular level, which presents as nodular skin lesion. Some of the examples are psychosis barbae, furuncle, carbuncle. And again, coming into non-follicular causes like ecthyma, cellulitis, erysipelas, paronychia, necrotizing lesions. Now, as I told you earlier, secondary pyodoma. That is, already some lesion is there. Over there, because of itching or due to any secondary applications, we are getting some bacterial infections. Sometimes these infections can become superficial also, which is called as bacteremia, which will further go into complicated conditions like bacterial endocarditis also. We will be seeing all those in upcoming slides. So we know that in intact skin, only gram-positive organism can be seen commonly. Such examples are Staphylococcus aureus and beta-hemolytic streptococci. Rarely other organisms like non-group-A streptococci, Streptococcus pneumoniae, Staphylococcus epidermidis, and Enterococcus can also be seen. And I told you because of certain toxins, it can go into systemic cause also, like Staphylococcus scattered skin syndrome, toxic shock syndrome, Staphylococcus sclerotina, recurrent toxin-mediated perineal erythema. These are conditions which can cause systemic involvement also. Still, there are rarer classifications, like skin lesion attributed to allergic hypersensitivity because of streptococcal antigens, like erythema nodosum vasculitis, and skin disease provoked or influenced by streptococcal infections, like psoriasis, particularly gutted forms. So now we are going into the first condition, that is impetigo. Impetigo is derived from a Latin word impetire, that is to attack. It's a communicable infection. Usually occurs in the preschool age children. It is a superficial pyogenic infection. The main predisposing factors are warm climate, crowding, poor hygiene, and neglected minor trauma. So the pathogenesis is staphylococcal toxin strain. It goes and it produces exfoliative toxin, which actually damages the desmoglein 1, which is the intracellular adhesion molecule. That's why we are getting bullous kind of lesions. There are two types actually, can be bullous and non-bullous also. So the incubation period of impetigo, it ranges from 1 to 3 days after exposure to streptococcus, whereas 4 to 10 days after exposure to staphylococcus. Again, about individual classification, that is non-bullous impetigo. This is very common among impetigo. In non-bullous form, it is very common and it is usually seen in the school-going age group. It initially starts as a small vesicle or pustule, then it becomes crusted like a honey-colored crusted plaque. So it looks like a dry crusted lesions, it always heals without scarring. And the common site are exposed areas like around the nose, mouths, limbs, and usually it gets cured spontaneously. In some cases, in heavily pigmented skin, we can see hypo or hyperpigmentation following the infection also. The next thing is bullous impetigo, which is caused by Staphylococcus aureus. Again, in this condition only, we are going to see multiple flaccid bullas. It usually occurs in neonates. So, usually a painless flaccid bulla with erosions, it usually occurs in the perianal area, again in the mouth, all over the body, it can occur. So, as we told earlier, it is because of exfoliative toxin, right? So, you will find a split in histopathology at the epidermal level. So, this is how the impetigo will present. These things are bullous impetigo. Can you see a well-defined fluid-filled bulla seen over the body? Can you see these are flaccid bullas? This is bullous impetigo. Whereas here we are not finding any bulla, it is just a honeycomb crusting, a crusted plaque. It is seen in the perioral areas, in face. This is non-bullous impetigo or impetigo contagiosa. Again, the same thing. These are neonate. With the look, you can tell these are neonates. So, here it was a large bulla which has eroded. These are bullous impetigo, and here also some of the lesions are bullous. Again, bullous impetigo. Now, we are going into difference between the bullous and non-bullous impetigo. First thing, we know the bullous impetigo is caused by Staphylococcus aureus, whereas non-bullous impetigo, it is mainly caused by Streptococcus pyogenes and Staphylococcus aureus. And again, this occurs in the infants, whereas this non-bullous impetigo in school-going age group. Then, the flaccid bulla occurs in bullous impetigo, whereas here the bulla gets eroded and we only find the honeycomb crusting. And extension usually extends peripherally with central clearing, bullous impetigo. But in non-bullous impetigo, without central clearing, we will find the peripheral extension. Lymphadenopathy is very rare in bullous impetigo. It is very common in non-bullous impetigo. And complication, usually bullous impetigo goes into complication, like Staphylococcus scaled skin syndrome. Whereas in non-bullous impetigo, post-streptococcal glomerulonephritis is a common complication. See, as you mentioned, any form of impetigo can go into post-streptococcal glomerulonephritis, osteomyelitis, septic arthritis, pneumonia, septicemia, rarely cellulitis, and fever. So, what are the differential diagnoses? We know that there is a bulla. So, automatically the diagnosis goes like immunobullous disorder or any localized form of Staphylococcus scaly skin syndrome or any contact dermatitis because of any irritant bulla can develop. And next one is herpes simplex infection. But the thing is here, we usually find a small vesicle instead of a large bulla. So the investigation, what we can do is we can just take a skin swab, do a gram stain, and we can look like what is organism, either it is Staphylococcus or Streptococcus. So treatment purpose, the main thing is impetigo, if it is localized, you always remove the crusting. That is very important because without removing, if you keep on applying the ointment, nothing will work. So how to remove the crust? Those things are by giving soaks, saline soaks. You can remove the crust. Then you can give an antibiotic. If it is localized, usually topical antibiotic is enough. If it is extensive, then we are going into systemic antibiotics, particularly first generation cephalosporins or penicillins. Next, we are going into ecthyma. Ecthyma means breaking out. It is an infection which is characterized by the adherent crusting. This is a little bit deeper pyoderma. So, in this, the crusting will be looking like a chocolate colored crusting. So, the pathology is as follows. Epidermis is lost, ulceration, and it heals with scarring because naturally it is a deeper infection. So, it usually heals with scarring. Positive organism. It's a group A Streptococcus. Rarely Pseudomonas aeruginosa or Staph aureus. So, how it present is a smaller pustule at an erythematous base. Then it increases in size and in duration. It becomes very thick, chocolate colored plaque. Like this. In this image, if you can see, it looks very deeper. Like it is very thick. This chocolate colored crusting is seen. If you try to remove it, definitely it's going to scar. Next, differential diagnosis. The common things are pyoderma gangrenosum, ecthyma gangrenosum, tick bites. And the complication, it can increase number of lesions, it can go into septicemia also. The investigation is same for everything. It's a swab. So treatment for all bacterial infection in general, the treatment is going to be same. If it is localized, it is always a topical fused cream or mucorous. The second line drugs we have, if it is not settling, if it is there for a longer time, then it's systemic also. Then we will always suggest you to start off oral antibiotics like penicillin or first generation cephalosporin, even oral erythromycin or doxycycline. Next, going into folliculitis. Now, this is actually a follicular infection. So, infection of the hair follicle. The inflammatory lesion is only confined to the hair follicle. That too, it is not extending below the ostium. So, it is superficial. The causative organism is Staphylococcus. So, this is how a follicular, I told you, follicular and non-follicular. This, if infection occurs only in this area, this is follicular. Again, if it is superficial, it is superficial follicular. If it is going deeper, involving the end of the follicle, then it is deeper infection. So now coming into types of folliculitis, we have superficial folliculitis, deep folliculitis. In superficial, it can be acute superficial folliculitis or Bocard's impetigo, chronic folliculitis of leg, gram-negative folliculitis, which is usually secondary to hot tub folliculitis or post-acne treatment. And deeper folliculitis, we have psychosis barbae, pharyngeal, and carbuncle. So coming into superficial folliculitis, we know it is also called as Bocard's impetigo. It occurs only till the ostium. It doesn't goes beyond this level. And it is caused by Staphylococcus aureus, usually occurs in the scalp and extremities. Naturally, where will we find the hair follicle? Usually in the scalp and in the extremities. So it occurs there only. So how it appears is like a pustule because it is follicular. So we will find only a pustule with the surrounding rim of erythema. And the lesion heal without scarring because this is superficial. And if it is chronic and recurrent, we should always think about diabetes and other underlying causes. In HIV, again, there will be a recurrent folliculitis. So, if you see, it is a pustule with surrounding rim of erythema. In center, actually, you can find a hair follicle also. So, this is a superficial folliculitis or Burkhart's folliculitis. So, can you see only the follicular lesions are getting involved? Like multiple smaller pustules are seen, particularly in the hair-bearing areas. Next, chronic folliculitis of the lip. This is a little bit rarer variant. It is also called as dermatitis cruris pustulosa atrophicus or Nigerian shin's disease. This chronic, again, it is caused by Staphylococcus aureus, usually seen in the males. Here, in the legs alone, you will find symmetrical follicular pustules. It is a long-standing condition and recalcitrant condition. Usually heals with scarring. So, this is a picture which depicts the level of infection. Like in superficial folliculitis, the infection is here. In deeper folliculitis, you can see the inflammatory lesion extending beyond the level of ostium. Again, in furuncle, it is a red tender nodule. So, numerous inflammatory lesions are there. Carbuncle, it means multiple furuncle joins together to form a carbuncle. See, here two follicles are involved and multiple inflammatory lesions are also there. Treatment, as I told you earlier, first line, we should always clean the wound, remove the pus collection or any scabs. Then you can give an ointment, antibiotic ointment like fused cream or mucorosine and oral antibiotics also. So these are second line drugs. Rarely, fluoxetine, clindamycin, everything can be tried. Now going into deeper folliculitis, which is psychosis barbae. As the name suggests, psychosis barbae means in the beard area. It's also called as barber's itch. It's like fig-like appearance. It occurs in young male. It's a chronic subacute pyogenic infection involving the entire depth of the hair follicle, particularly in the beard area, caused by Staph aureus. So again, as we know, all the folliculitis lesion will occur as a particular pustule only. So erythematous follicular papule or pustule, which is always having a hair in the center. Sometimes it can collapse to form a large flock also, studded with pustules. So it is commonly seen in the nape of the neck or in the beard areas. Deeper folliculitis is associated with destruction of hair follicles and scarring also. So treatment, again, topical therapy with antibiotics. Rarely, to reduce inflammation, we can start steroids also. Second line, systemic antibiotics such as cloxacillin, erythromycin. Third line, laser hair removal. So next, going into furuncle. Furuncle, it is also known as a boil, which means petty thief in Latin. It's a deeper follicular infection of an hair follicle. Again, here you will find a pustule and also a nodular kind of thing because there are more inflammatory infiltrate around the perifollicular region in the dermis and subcutaneous area. So can you see it doesn't look superficial. So it is actually going deep because it is affecting the entire length of hair follicle. So here these things are furuncle. That is a particular hair follicle is affected, but the inflammatory lesions are more that it appears like a nodule. Treatment, here it is better to start oral drugs initially. So penicillin or first generation cephalosporin, fluoxacillin, erythromycin. Even you can try combinations like clindamycin plus rifampicin plus decolonization, linezolid plus rifampicin plus decolonization. So if it is very large and pus collection is more, then you should do a incision and drainage also under aseptic precaution. So next, going into a carbuncle. Carbuncle means charcoal. That is, it is similar to furuncle, but when a multiple furuncle joins together to form a larger lesion, it is called as carbuncle. So it is a deeper infection. Group of hair follicles are affected. So intense inflammatory infiltrates will be seen in the connective tissues also. So this is how it appears. You can see multiple hair follicles are affected. Actually, this is a multiple furuncle which is joining together to form a carbuncle. And you can see the pus collection also. So it appears like a larger lesion, sieve-like appearance of pus. That is, larger lesion with multiple pus pointing will be seen. Again, for this condition, predisposing factors is usually diabetes mellitus, immunocompromised state like HIV, or on steroids. The common site again, nape of the neck, shoulder, hip, and thigh. So how will it start is, it's usually starting as a smaller pustule. It's painful, tender, then it becomes indurated and it affects the surrounding tissue also. So the suppuration, that is pus collection, begins after 5 to 10 days and multiple pus point will be seen because multiple follicular unit is affected. So multiple pus pointing will be seen, which gives appearance like a seam. And since it is deep issue, it usually heals with scarring and pigmentation. Treatment, most of the things, the same treatment, flucloxacillin, incision and drainage. Again, this is a smaller slide which shows the difference between the furuncle and carbuncle. In furuncle, only one follicular unit is affected. It is caused by staph aureus. Usually, symptomatic other symptoms like fever is less, and it is a hard, tender nodule, single nodule, which is becoming fluctuant on upcoming days. Pus discharge can be seen, whereas in carbuncle, you can see the sieve-like appearance. Multiple pus pointing, multiple hair follicles are affected. It's caused by staph aureus. Usually fever and other symptoms are also associated. And painful discharging of pus is seen at multiple points. Now we are going into next entity, which is deeper, yet it is not a follicular. So non-follicular deeper infection, which is cellulitis. Cellulitis also as common as impetigo. So cellulitis, it presents as acute, subacute or chronic inflammation of loose connective tissue. More common in lower extremities. So in legs, usually unilateral. It is produced by group A streptococci and streptococcus aureus. Rarely caused by Haemophilus influenza type B, which can cause facial cellulitis in children. Pneumococcal, diabetes, and other immunosuppressive stages. So, what are the triggering factors? Like, if patient is already having a long-standing tinea pedis or any fungal infection, eczema, ulcer, he's repeatedly scratching his legs because of any trauma or burns, diabetes, which is causing further infection. So, whenever a skin is intact, it's okay. Because of any underlying factors, if the skin is not intact and he's keep on scratching, the outer bacteria usually enters the skin, then it produces bacterial infection. And here the constitutional symptoms are more like fever, malaise, and chills. And how will it present? Since it is non-follicular, it is going to involve the entire area. Like you will find the redness. Erythema means redness, induration, that is thickness, and tenderness, pain. It is found all over the area, like on the leg, entire leg. And lymph nodes are usually enlarged and tender. Lymphangitis will also be seen. And in Staphylococcus aureus infection, we will find pustules additionally also. So this is how a cellulitis will present. Initially starts. Here might be he would have had some candidiasis or tinea pedis because of scratching. Some bacteria have entered and entire leg is getting involved. Can you see the redness, erythema, and skin peeling is also there. First discharge is there. The leg is swollen and tender lymph nodes will also be there. Next, erysipelas. Actually, it's very difficult to differentiate cellulitis and erysipelas. Erysipelas means reddening of skin. It is also a superficial form of cellulitis, yet it is a deeper non-follicular infection. The common site is face and scalp. So how will this present is usually it doesn't go beyond the dermis, whereas cellulitis it goes beyond the dermis to subcutis also. So here it will present as a bright red flock, well demarcated, whereas this will not be seen in cellulitis. Demarcation will not be seen. So here well demarcated, edematous, indurated flock, which is warmth and tenderness is also there. And we can see the superficial bulla also. Constitutional symptoms can also be seen like fever, malaise, and chills. Rarely lymphadenopathy, lymphangitis can also be seen. So what is the treatment? The first line of treatment is fluoxetine, clarithromycin, clindamycin, and benzylpenicillin. Second line is roxithromycin, penicillin, erythromycin. So actually, if you want to know the difference between the erysipelas and cellulitis, the main thing is erysipelas is little bit superficial and it is always well demarcated. Whereas this cellulitis, it is deeper, it is going towards subcutis also, it is not well demarcated and you can see the puckering appearances also. And superficial bullas, vesicles, these things are common with erysipelas when compared with cellulitis. So next we are going into some of the superficial infection which is progressing towards the bacteremia, that is systemic infection also. Staphylococcus Galder-Skin syndrome. It is also called as Ritter's disease. So here, as we learned earlier in impetigo, the same mechanism, exfoliative dermatitis. So most of the body surface area will become tender, erythematous, and peeling will also be seen. The pathology is the epidermis gets split between the granular layer and spinous layer. That is, a cellular level destruction is seen. The causative organism, as we know, is Staph aureus, phage type 71 or 55. So the child will have severe systematic symptoms also, like fever, skin tenderness, erythema, particularly in the folds, like neck folds, groin, axilla. This infection usually spars palms and soles and mucous membrane. Nikolsky sign is always first. What is Nikolsky sign? Whenever we find a bulla, if we try to extend the bulla, it might spread. That is Nikolsky sign. So when the bulla is there, in next few hours to days, it usually gets exfoliated. Again, the investigation for all bacterial infection is going to be a smear. And histopathology also. Here, why? Because we are going to see the split. So this is how the bacteremia of Staphylococcus Galder-Skin syndrome present. Particularly in the flexures, as you can see in the axilla, you will find the indurated erythematous lesions. So differential diagnosis is one more systemic infection, which is toxic epidermal necrosis. Investigation, we can also do PCR for looking at the toxin. ESR is usually elevated in all inflammatory conditions. Treatment, the first line is fluoxetine, clindamycin, tigecycline, and daptomycin. If the infection is MRSA, that is methicillin resistant Staphylococcus aureus, usually we are going to treat with vancomycin. So next coming into toxic shock syndrome. Here this toxic shock syndrome, as the name suggests, you will have the features of shock. So more of the systemic complaints than the skin complaints. So here the patient will have fever, erythema, desquamation, that is peeling of the skin, circulatory shock, that is very important, That is, multisystemic involvement will be there because of toxin produced by Staphylococcus aureus or Streptococcus pyogenes. So usually we will find a perivascular mononuclear cell infiltrate and edema in histopathology. Causative organism, as we know, Staph aureus and Streptococcus pyogenes. So complication is multi-organ failure. So slowly we'll have all the symptoms starting from the CNS to the liver to the kidney, heart, everything will start to fail. So here we have clinical features. The rashes can be there along with fever, vomiting, diarrhea, multiple organ failure. The erythema, the rash which I told you is usually it's very faint and it gets cleared within 3 days. Can also present like a sclerotinic form or papulopustular lesion, and edema will be there. Generalized erythema and edema will be there. So all the mucosas will also start to have the erythema and it can ulcerate also. So treatment here is first line. First, you have to stabilize the patient. Hemodynamic resuscitation should be done. IV clindamycin along with benzyl penicillin sodium can be or vancomycin in case of MRSA. Second line for severe cases, we usually add IV immunoglobulin also at a dose of 2 gram per kg. Then on follow-up, we can reduce it to 0.4 gram per kg. Now we are going into some of the Corynebacterium infection. So far, we have seen that only the bacterial infection. So before going into Corynebacterium infection, in general, about treatment of bacterial infection. So we know that most of the infection is caused by gram-positive organism only. So the treatment is also going to depend on that. So for all the infection, the first thing is you have to first clear that scab or any crust by giving saline soaks. Or there are many soaks like KM104 soaks. You just what is a soak is actually you have to soak some cotton cloth in hot water or any salt water. Then you put it over the lesion so that the crust becomes soft and it gets peeled off. And the pus, if it is there, it will get collected also. So it will help us to apply the ointment and get absorbed easily. And about the systemic, topical drugs, we have many drugs. Among that, what we use is topical fusigen or topical Neupros. And going into the second line, that is oral antibacterial. So when should we start oral antibacterial is again a very important thing. For systemic causes, we usually start. But if a lesion is very localized, it is not causing any symptoms, like the lymph node is not there, there is no systemic complaints like fever or body ache, and it is not going deeper, then usually we can give topical creams alone. But if it is in danger areas of the face, lymph node is there and fever is there, systemic complaints, constitutional symptoms are there, and it is not at all reducing with topical treatment, and the patient is immunosuppressed also like diabetes, or yeah, he is on ATT or any form of drugs, then it is usually better to start oral antibacterial also. So again, while starting oral antibacterials, what should we keep in mind is the organism is usually gram positive. So we can basically start with penicillin also, like amoxiclavulinic acid, so that we can cover both the resistant strain also. Or if we are starting cephalosporin, we should always, we can give first generation itself because we are going to treat only the gram positive organism. So the drugs like cephadroxil, we can easily start them. So if it is a serious condition like cellulitis, then patient is not stable, then you have to give IV drugs. Again, there are some conditions like necrotizing fasciitis also, which means if you are not treating the cellulitis or any bacterial infection, it is progressing, it is going beyond the subcutis and it's affecting the fascia also. In such cases, you should always do a fasciotomy so that you are letting the muscle free without getting infected, and we have to start IV antibiotics like any clindamycin, anything, drug of choice. So now we are going into rarer causes. Corynebacterium infection, we have some 3 to 4 diseases. First one is erythrasma. Erythrasma, it is characterized by sharply demarcated dry brown, slightly scaly patches in the intertriginous area like axilla, rib space between 4th and 5th toes. So the symptoms, it is usually asymptomatic. Rarely you can find itching and burning sensation also. And if diabetes is there, it is always a predisposing condition. So the causative organism here is Corynebacterium minuticilla. It is a cutaneous granulomas or bacteremia. This Corynebacterium minutissimum can also cause pitted keratolysis and trichomycosis axillaris also. So in the picture, if you can find, it is a well-defined hyperpigmented macule in the axillary area. So you should always keep in mind the erythrasma. What are the other differential diagnoses for this condition? It is always a fungal infection. It can be a pityriasis versicolor. So how will you diagnose? Same the gram stain. If you do a KOH, you can rule out pityriasis versicolor. And if you do a gram stain, then we can easily find the Corynebacterium. That is a gram positive rods. So as I told, differential diagnosis includes tinea puris, seborrheic dermatitis, inverse psoriasis, candidiasis, and lichen simplex chronicus. And one more thing is here, along with the gram stain and KOH, we can always do a Woods lamp examination. In Woods lamp, it's nothing but an instrument which emits a light. So Woods lamp, if you try to keep it on that emission, you will always get a coral red fluorescence because the Corynebacterium minutissimum will always produce a porphyrin, which will produce a fluorescence. That is, a coral red fluorescence will be seen. So this is one of the important differentiating point for erythrasma. And again, for Corynebacterium, the treatment varies. Topically, we can give erythromycin or clindamycin. Orally, you can give erythromycin 250 mg for 1 week. Topical miconazole can also be given. We are giving antifungal for erythrasma just because the clotrimazole, miconazole, these things has anti-inflammatory property also. That's why we are giving antifungal for a bacterial infection. Next thing is pitted keratolysis. Pitted keratolysis is also called as keratolysis plantaris sulcate. It is again a bacterial infection of plantar area. That is, you can find this only on the soles. It is also called as keratoma plantare. So whoever is wearing the shoes, has a sweaty shoes, they are presenting for a longer with humid weather and it's very hot, then usually they will be getting pitted keratosis. Again, this is also an asymptomatic infection. So it is actually an incidental finding only. And it is caused by Micrococcus sedentarius, Dermatophilus congolensis, Phytococcus sedentarius. These things will act by degrading the keratin. That is, it is, as a name suggests, there will be multiple pits. So clinical features, how will you find this? Multiple shallow asymptomatic pits of 1 to 3 millimeter, which is confined to form a burrows. This pitted keratolysis. So if you usually it occurs in the immunosuppressed patients like diabetes also. So multiple pits, it's a crater like pits of diameter 1 to 3 millimeter is seen here on the soles. So first thing you have to treat is they have to reduce the sweating on the sole, that is hyperhidrosis. How will you reduce the sweating on the sole? By giving aluminum chloride solution and modifying, like they have to avoid shoes till it gets healed. Then they have to wash their legs frequently and apply the topical bacterial agents and antifungals also you can try. And orally you can give erythromycin. So histologically, we see a keratin pits, which is lined by cocci and filamentous bacteria. So topical, as I told you, topical erythromycin or clindamycin, miconazole, clotrimazole again for the anti-inflammatory properties. Benzyl peroxide gel, which is available in 5%. And as I told you, to reduce the sweating, we again give the 10 to 20% aluminum chloride solution also. And coming to botulinum toxin, why should we give it here? Because the increased sweating in the soles will further increase the episodes of pitted keratolysis. So that by giving botulinum toxin, the sweating can be reduced. So in order to treat that sweating, we are giving botulinum toxin. So this is also coming under the treatment of pitted keratolysis. And one more infection again, which we have left is among the Corynebacterium infection, trichomycosis axillaris. Tricho, as a name suggests, in axillary hair, you will find a crystals, yellowish crystals like thing. This is called as trichomycosis axillaris. It is again caused by a Corynebacterium only. So it is easily identifiable because of the yellowish crystals covering in the hair shaft. So what is the treatment? As we know, for all Corynebacterium infection, we are going to give erythromycin. Topically, if used in cream or orally erythromycin will be starting. Since it is axillary hair, you can better do a shaving also to reduce. Thank you.